Okay, hello everyone. Thank you for coming to this continuing education presentation where my co-residents and I will be presenting our research, and I will get us started. So my name is Erin Tersenio. I am a PGY1 pharmacy practice resident, and my research this year was looking at the utility of intravenous pentamidine infusions for pneumocystis pneumonia prophylaxis and hematological malignancy and hematopoietic stem cell transplant adults. I would like to acknowledge Dr. Tyler Hertz and Dr. Saitia, one of our infectious disease providers, for helping me and working with me extensively on completing this research project. None of the authors, including myself, have anything to disclose. Our pharmacist objectives for today will be to identify the utility of once monthly intravenous pentamidine infusions in this patient population that I looked at for my research, and for technicians to discuss the utility of those once monthly pentamidine infusions. Now, before we get into the core of my research project, let's talk about some background and explain what pneumocystis pneumonia is. Pneumocystis pneumonia is a serious fungal opportunistic infection caused by Pneumocystis jirovecii, or PJP. Now, some of us may be more familiar with the abbreviation PCP. The reason for that is scientists have changed both the classification and the name of the organism since it first appeared back in the 1980s. It used to be known as a protozoan called Pneumocystis carinii, hence PCP, but it is now considered a fungus, Pneumocystis jirovecii. Both of the abbreviations are accepted and utilized in literature as well as accepted by the CDC. How are doctors going to diagnose PJP? They would utilize this doing a differential diagnosis if patients have respiratory symptoms. They can utilize sputum samples as well as a bronchoalveolar lavage, or BAL. A BAL is a diagnostic technique that uses a bronchoscope to collect specimens from the lower respiratory tract for testing. PJP is spread from person to person through the air. Healthy adults can carry the pneumocystis fungus in their lungs without having any symptoms, but they can still spread the Pneumocystis jirovecii fungus. This is also true with children who may be exposed to Pneumocystis jirovecii but will not have any symptoms. And that is because of our host natural immune system. So it is extremely rare for healthy individuals to have a pneumocystis pneumonia infection. However, the mortality rate significantly increases in patients that are immunocompromised. So they estimate about 30 to 60% mortality rate in non-HIV high-risk patients in the absence of adequate PJP prophylaxis. And the mortality rate also does increase in immunocompromised patients that have HIV. Patients that have high-risk regimens, so including having chemotherapy regimens or allogeneic hematopoietic stem cell transplant, that would all put a patient at risk for developing a pneumocystis pneumonia infection. So because of this, the National Comprehensive Cancer Network guidelines, or the NCCN guidelines, as well as the CDT, recommend routine PJP prophylaxis in immunocompromised patients. They recommend as a first-line regimen for prophylaxis with trimethoprim sulfamethoxazole, or brand name Bactrim, and second-line therapies for patients who can either not tolerate or cannot take for any reason Bactrim, pentamidine, atovaquone, and dapsone. Now, since my research focused specifically on pentamidine, I would just like to take some time to compare pentamidine to our first-line recommendation, Bactrim. It's available as an oral tablet once daily, or alternatively one double-strength tablet 3 times weekly, which we might be more familiar with in terms of orders here at Stony Brook. There are a lot of adverse effects that go along with administration of Bactrim, including rash, and in more severe cases, Stevens-Johnson syndrome. Of particular interest when we're thinking about the patient population that I looked at for this research project, including those who have hematological malignancies or post-transplant, chronic use of Bactrim can cause bone marrow depression. So this is something that these patients are already at risk of. So because of this, providers might be looking at alternative options for adequate PJP prophylaxis, which brings us to pentamidine. Pentamidine is available in different formulations, including an infusion dosed as 4 milligrams per kilo IV once a month, which is also nice because it provides less administrations for patients if they're willing to get IV infusions. It's also available as an inhalation through a nebulizer. However, this nebulizer may not be available at some institutions, and with the resurgence of COVID, we may want to avoid some nebulized therapies. Given that information and that my research is focused on the infusions, let's talk about the adverse effects of these infusions. There are a risk of injection site reactions. There are also renal concerns, including renal insufficiency, as well as increases in patient serum creatinine, so something to monitor for. as well as cardiovascular concerns. This includes transient hypotension while patients are receiving the pentamidine infusions, as well as tachycardia, including QT prolongation. So now we know that Bactrim is the first line agent, but there is a role for alternative agents if patients are post-transplant or if they have hematological malignancies, also if they have sulfa allergies as well. So because of that, we look specifically at if patients were getting pentamidine as their prophylaxis regimen, how well did this actually prevent PJP? And that was our primary objective. For secondary objectives, we looked a little bit more in detail, thinking about did providers utilize pentamidine as a first line or second line agent? And then in terms of safety, we looked at if there were adverse events to the pentamidine infusions, and then we quantified those and explained what were those adverse effects. And in order to do this, we did a retrospective chart review, and we looked at data from January 1st of 2016 to August 27th of 2021. We collected variables through the EMR and Cerner's power chart and utilized statistical analyses with descriptive statistics. We included all adult patients that were admitted to the bone marrow transplant unit, so 19 South, the Mart Building Infusion Center, and the Cancer Center, as long as they received at least one dose of IV pentamidine as PJP prophylaxis. When we collected this data, we found 72 cases that met the inclusion criteria. The mean age was 54.9 years, and the majority of these patients were male sex, 59.7%. Now circling into my overall results, on the screen in the table, we have my primary and secondary objectives. We'll start focusing on our primary objective, and then we'll circle back to secondary later on. As you can see, there were no cases out of the 72 patients we looked at that had a positive confirmed PJP infection while they were receiving pentamidine for prophylaxis, which is great. But I do want to transition to this next slide that explains this a little more in depth. So when we looked more in detail at these cases, we did find that there were 4 cases in which patients required temporary discontinuation of pentamidine because the team was suspecting a PJP infection, meaning patients had respiratory symptoms and the differential diagnosis was not as clear. In these 4 cases, the team consulted infectious disease and they did a PJP workup, which included looking at radiographic imaging, looking at sputum samples, the BAL and PCR for PJP, like we talked about on the earlier slides. Out of these 4 patients, after a workup by infectious disease, one of those patients was considered to have a probable PJP infection, but not confirmed. The reason for this was because the radiographic imaging of this patient was not consistent per infectious disease and what they would typically find in a patient who had a positive pneumocystis pneumonia. Also, this patient's PCR and BAL were only weakly positive, and the patient's symptoms were respiratory, however, including increased sputum production, dyspnea on exertion, as well as a fever. So because of all of these factors, the team decided this was maybe a probable infection. They recommended to continue only with prophylaxis dosing, not treatment dosing for pneumocystis pneumonia. But overall, there were 0 confirmed cases of PJP. Thinking about secondary objectives, the majority of these patients who received pentamidine actually did receive it as an initial prophylaxis regimen, about 78% of these patients. When we looked at that a little bit more in depth, we found the majority of the reason, for 51%, was due to patients having leukopenia and neutropenia. So providers did not want to exacerbate this when utilizing Bactrim. That followed by a reason that was really unclear. I really relied on provider documentation to give reasoning, followed by patients being on methotrexate, typically high-dose methotrexate, as there is that interaction with Bactrim. It can increase the effects, the toxic effects of methotrexate that could lead to potentially even fatal myelosuppression, and then if patients had a sulfa allergy. The remaining 22% received pentamidine as an alternative regimen, so after something like Bactrim. And the reasons for this was pretty consistent with what we found if they were using it as an initial regimen. So due to a new onset of neutropenia, leukopenia, also about 19% of the cases, patients developed a rash to Bactrim. The reason was unclear, and then as well as methotrexate being added. Now diving into the safety. So out of the 72 cases, only 5 patients had an adverse reaction that was attributed to the pentamidine infusion, which constitutes for about 6.94%. I stratified the adverse effects based off of the CTCAE grading scale, so the common terminology criteria for adverse events by the Department of Health and Human Services and National Cancer Institute. This CTAE grading scale grades patients from their adverse reactions from grade A to 5, 5 being the most severe of death and 1 being mild. As you can see on the right-hand side of that table, the highest graded was only a 2, being a moderate adverse reaction. And a lot of these adverse reactions were things we talked about earlier that we might expect, including hypotension, so transient hypotension while the patient received pentamidine, increases in serum creatinine, also saw some cardiovascular things like tachycardia as well. And I will say the majority of these patients, providers were able to just stop the infusion. Patients did resolve with their adverse reactions, and they oftentimes even continued with pentamidine for future prophylaxis doses, just gave pre-medication based on provider discretion. Now getting into the conclusion, before I think it's important to consider many of the limitations in this study. So it is retrospective in nature. There was no control group, so I really couldn't assess for clinical outcomes. I couldn't fully assess the safety and efficacy of pentamidine infusions for PJP prophylaxis. I did also have a limited patient population with only 72 patients, and I really did rely on accurate and detailed provider documentation to get my objectives. But overall, based off the data, I concluded that IV pentamidine can be utilized for pneumocystis pneumonia prophylaxis in these immunocompromised patients. The infusions did seem to be pretty well tolerated. Only 6.9% had adverse effects, and it does offer reduced medication administrations as compared to an option like Bactrim. So that concludes my research. I will now hand this over to my co-resident, Dr. Stephanie Katartzis, who will present her research to you, and we will save all questions for the end of the presentation.
Good evening, everyone. So thank you, Erin, for the introduction. I'm going to be presenting my longitudinal research project on the utilization of Bayesian-guided area under the curve monitoring software in comparison to traditional trough monitoring for vancomycin dosing in the pediatric patient population. I have nothing to disclose, and I would like to acknowledge Amanda for being my research mentor for this project. So the learning objectives for today are for pharmacists to outline the differences in vancomycin's traditional trough-based monitoring versus the Bayesian-guided area under the curve monitoring in the pediatric patient population. And for technicians to just review the different therapeutic drug monitoring methods for vancomycin. Now, before we go into my project, some background information for vancomycin. So vancomycin is a glycopeptide antibiotic that is used to broadly cover a lot of gram-positive bacterial infections, predominantly methicillin-resistant Staphylococcus aureus, or MRSA. And since the medication does have a high risk of causing acute kidney injury, it is recommended to have therapeutic drug monitoring, or TDM, to help ensure therapeutic efficacy and that the vancomycin is treating the infection as well as minimizing the risk of kidney injury. There are also two different branches of therapeutic drug monitoring. We have the traditional trough-based monitoring that we may be more familiar with, as well as the AUC-based monitoring. So what is AUC? AUC stands for area under the curve, and it represents overall drug exposure. So when looking at the AUC of vancomycin dosing, it represents the cumulative vancomycin concentration in the blood over a period of time, usually over 24 hours. And the goal here is that we want to achieve serum concentrations at a certain ratio above the minimum inhibitory concentration, or MIC, for vancomycin to exert its bacteria killing effect. So MIC is the lowest concentration of antibiotic that inhibits the growth of a given strain of bacteria. So for vancomycin specifically, we aim for this ratio of an AUC of 400 to 600 over MIC of 1. And just to compare it to trough levels, so again, the AUC is this cumulative drug exposure over a period of usually 24 hours versus a trough level that serves as a single exposure point at the end of a dosing interval. Now, there's different ways to calculate the AUC. Usually we use hand calculations, but there are also softwares that can do the calculations for you. At Stony Brook here, we use Precise PK, which is special in that it also adds this Bayesian method to the vancomycin dosing. And that means that the system uses prior population data from literature to predict how an individual's PK parameter values will be and estimate how the drug will behave in the individual. So when we enter the patient's demographic information, the program is going to automatically select the best population model model from literature that is most representative for the patient. And this allows pharmacists to help develop initial dosing regimens and then individualized dosing when we get serum concentration levels back from that specific patient. And more information in regards to use of vancomycin in the pediatric population. So as I mentioned earlier, the goal AUC to MIC in adults is typically the 400 to 600 range. However, in children, there's really no literature to support using the higher end of that range. So we try to aim as close to 400 as possible. So usually the 400 to 500 range. And a lot of this AUC-based dosing is extrapolated from the clinical outcomes of adult studies. So that's something to keep in mind as well when looking at its use in the pediatric patient population. There's also conflicting data on the correlation of trough and 24-hour AUC. Some studies say that they do correlate, some do not. And in regards to the dosing of vancomycin, typically it's dosed 45 to 60 milligrams per kilogram per day. However, the new 2020 ASHP guidelines mentioned that it may be needed to push those doses to more of the 60 to 80 milligram per kilogram per day age range to get adequate dosing for these patients. So the main research question for my project is, does using a Bayesian-guided AUC software like PrecisePK for vancomycin monitoring result in a different dose recommendation than traditional trough-based monitoring? So basically, we're comparing the different methods of vancomycin monitoring and comparing the doses that come from those monitoring methods. So the study design is that it's a retrospective chart review of all the patients from Stony Brook Children's Hospital who required the use of intravenous vancomycin. So these patients were taken from the year 2020, since 2020 is the year where we did not have a pediatric pharmacist on the floor. And the dosing from that year is mainly trough-based, since we didn't have PrecisePK used on those floors then. So I took all these patients from 2020 who got the trough-based dosing for vancomycin and took their information and put it into PrecisePK, our PK vancomycin monitoring software, and looked at what the doses PrecisePK would have recommended for these patients and compared it to what doses they actually got when it was a trough-based dose. So I took all their information needed for that, including the vancomycin doses, administration time, serum concentration levels, serum creatinine for the patients, and then used in order to analyze my data, I analyzed it through descriptive statistics. Patients that were included in this study were all the patients who were admitted to Stony Brook Children's Hospital receiving vancomycin for at least 24 hours. And the patients who were neonates or over the age of 18 were excluded. And these patients needed to have a steady state trough level for vancomycin monitoring documented in order to be included. The patients that were included were further subdivided into 3 different groups due to the variability of pharmacokinetics and dosing between those different age groups. So we have infants, children, and adolescents. So looking at the results for this study, so 78 patient charts were reviewed, and 35 of those patients met inclusion criteria, representing 37 different encounters. And we have the table here for the demographic data for the patients. I have the average age listed for each of the different groups, and the male to female ratios were pretty split 50-50 in all the different groups. And for this slide, I'd like to emphasize the most common use warranting vancomycin was neutropenic fever, accounting for 12 patients, and coming in second and third were soft skin tissue infections and sepsis, respectively. This is a table compiling the comparison between the trough-based doses and the AUC-based monitoring. So again, I looked at the doses that they received in 2020 and compared it to what PrecisePK would have told me to recommend for those patients if we were to do it back in time. So this is the mean initial dose that they had. So it ranged anywhere from 50 to 60 milligrams per kilogram per day. The resultant trough level, as you can see here, ranged anywhere from about 7 to 10, and the estimated average 24-hour AUC ranged anywhere from 327 to 365. I also included other information here looking at the mean recommended dose change. So looking at how much PrecisePK recommended we increase the dose in order to get to therapeutic levels, as well as looking at the difference of the AUC and the trough-based doses. So it really wasn't too big of a difference looking at those averages. However, we can see the standard deviation is a bit high, so there's a high range. Some doses may have increased by 10 milligrams per kilogram per day, while some might have only increased by 1 or less than 1. So that's that table. And now this is where we're looking at the main question. If the trough-based dose falls in the recommended range of precise PK. So again, I used the AUC goals of 400 to 500 to see what doses they recommended to get patients in that range. And 45.5% of the patients had their trough-based doses fall in that recommended precise PK dosing range. The other half mainly was the trough-based doses actually fell under the recommended range of dosing, meaning that these patients may have been subtherapeutic with their vancomycin. I also have this scatter plot here looking at the correlation of trough and AUC values. As we can see here, as the trough level increases, the AUC levels increase, showing that there is a positive correlation. And if you look at the trough values of about 5 to 10, it correlated with an AUC between 300 to 400. And with the R squared value, which evaluates the scatter of the data points around the fitted regression line, shows that about 80% of the variation in the output variable was explained by the input variables. And before I conclude my study, I would like to go over a few limitations. So this was a chart review that was retrospective in nature. There were some confounders, including the absence of updated height and weight that are needed to input into precise PK and adequately dose a patient. There's also some inconsistent or unclear documentation. For example, sometimes it was unclear on whether or not the patient received their serum concentration level before or after the dose was given. The study was also limited in the fact that it was a single center study with a small sample size. And lastly, the PK software was not originally built to analyze retrospective data, and it didn't have too large of a selection of population-based PK studies for pediatric patients to use for their Bayesian modeling. So I would like to conclude that the AUC-based and trough-based dosing recommendations differed in the aspect that increased occurrence of trough-guided dosing recommendations were under the AUC-based recommended range, showing that the dosing by trough actually might have led to subtherapeutic dosing for these patients. And this could be due to the fact that the patients in 2020 usually got the 45 to 60 milligrams per kilogram per day. And as we know now, with the 2020 ASHP guidelines, they recommend dosing even a little bit higher in the 60 to 80 milligrams per kilogram per day range. And dose adjustments may be greater than the typical 2.5 milligrams per kilogram per day that we may have used in the past to get patients with adequate levels. There was also the average estimated initial 24-hour AUC of less than 400, showing that the levels may not have been, the dosing may not have been also as adequate for dosing and subtherapeutic. But this can be due to the timing of when the levels were taken. So we get the levels for vancomycin before the 4th dose, but in these patients who are getting the vancomycin every 6 hours, by the time we get their level before the 4th dose, they only got maybe 18 hours of vancomycin exposure. So it may be more prudent to actually take the level before the 5th dose to when the vancomycin would have fully distributed and get where it needs to be in the body. I'd also like to conclude that since this process of AUC monitoring could be more time intensive with the software and the fact that physicians are less familiar with the use, the patients who are receiving vancomycin for over 48 hours may be more beneficial to do the AUC monitoring in this population. Since in the study, about half of the patients actually only got 1 serum concentration level, and then the medication was discontinued after maybe 1 more dose. So it may be more helpful to monitor vancomycin in patients who are actually going to stay on it for more than 48 hours. Also, another pro to using the PK software is that there's greater flexibility in interpreting non-trough levels. In the study, we also did see a possible trend in correlation of trough and AUC values, but overall it is still contradicting based on previous studies that have been done. And lastly, I do want to emphasize again that the clinical outcomes of using AUC-based monitoring are unknown in the pediatric patient population, so future studies are needed evaluating these clinical outcomes. And that is all I have. And again, I'll be taking any questions at the end, but now I'm going to pass off to my co-resident Vincenza.
Hello, everyone. Hello, everyone. My name is Vincenza, and today I will be presenting my evaluation of an opioid withdrawal prophylaxis algorithm in the pediatric intensive care unit. My research team involved myself, Dr. Amanda Waldeck, and Dr. Randy Trope. The authors of this presentation have no financial interests, arrangements, or affiliations with any organizations that could be perceived as a real or apparent conflict of interest in the content of this presentation. Some learning objectives that I hope to achieve today are to assess compliance and efficacy to the opioid component of an institutional-based withdrawal prophylaxis algorithm, and to discuss the utility of a set methadone algorithm to prevent opioid withdrawal in pediatric patients. Our primary and secondary endpoints were to assess compliance and efficacy of an opioid withdrawal prophylaxis algorithm in the pediatric intensive care unit, respectively. Just to give a little bit of background before we begin, there is a high incidence of withdrawal syndrome occurring in pediatric intensive care units following continuous infusions of opioid analgesics for prolonged periods of time. Due to the prolonged exposure and increased cumulative doses of these agents in critically ill patients, there is a significant risk for withdrawal. Opioid withdrawal includes central nervous system irritability, anxiety, agitation, restlessness or seizures, gastrointestinal irritation such as diarrhea, nausea, or vomiting, and sympathetic nervous system activation such as tachycardia, tachypnea, or fever. Fentanyl and morphine are two of the most commonly used opioids for sedation and analgesia in PICUs. And treatment options after prolonged administration of these agents include slowly tapering the IV administration of these agents, or depending on the drug, switching to sub-Q or oral administration to prevent the development of withdrawal symptoms so that they can further be weaned. There's currently no gold standard on assessment as well as management of these symptoms, but a set algorithm to prevent these symptoms has been proven to reduce the incidence. In PICU settings, nurses will monitor their patients and assess their withdrawal symptoms utilizing this withdrawal assessment tool that I've included here on the slide for your reference. And this helps to determine and score patients on their degree of withdrawal. Symptoms typically include, again, that diarrhea, nausea, vomiting, fever, or sweating, as listed here on the scoring system. At Stony Brook, nurses will collect these scores every 4 hours to assess these symptoms. It's important to highlight that scores greater than or equal to 3 are associated with withdrawal and what we use to determine if the patient is withdrawing or not. In September of 2020, the Pediatric Intensive Care Unit at Stony Brook Children's Hospital implemented a withdrawal prophylaxis algorithm to help manage and prevent pediatric patients from experiencing these symptoms. The algorithm was divided into 2 pathways based on the length of mechanical ventilation, which would determine how to perform the methadone and continuous opioid infusion taper. If there was planned extubation in 1 to 2 days, patients were initially converted from their fentanyl or morphine continuous IV infusion dose to oral methadone based on our oral methadone conversion guide, which I will get into on the next slide. So again, depending on the length of mechanical ventilation, which was either greater than or equal to 14 days or less than 14 days, we would reduce the dose by either a 10 to 20% reduction or a 15 to 25% reduction, beginning with the second dose of methadone, respectively. The reason that the algorithm was set to begin after the second dose of methadone was due to the elimination half-life of methadone, which is about 12 to 24 hours, to help the drug achieve steady state to prevent this risk of withdrawal during the initial wean of the continuous opioid infusion. Watt scores were consistently monitored every 4 hours during the wean to determine the presence of withdrawal. And if determined that the patient was in withdrawal, which was associated with Watt scores again greater than or equal to 3, the algorithm would call for use of rescue doses or an increase in the dose of the continuous opioid infusion if it was still on. Once patients were off of their continuous opioid and Watt scores were less than 3, the algorithm called for a methadone taper by 10 to 20% of that maximum dose, depending on, again, the length of mechanical ventilation per each patient. When beginning the algorithm, we must convert the dose of the continuous opioid infusion, which was either fentanyl or morphine for purposes of our study. Conversion to methadone involved a 10 to 20% reduction in the max dose of fentanyl or morphine. This accounted for a 50 to 1 potency conversion for fentanyl and a cross tolerance reduction of 25%. I included a portion of our direct conversion guide for your reference. So for example, if the patient's rate of fentanyl was 1 mic per kilo per hour, then the oral methadone would be started at 0.02 mg per kilo per dose to be given every 6 hours. Now to get into the methods of our study. So this is a retrospective chart review of patients from September of 2020 through March of 2022, using data from Stony Brook Children's electronic medical records, or our Cerner's power chart. I included the inclusion and exclusion criteria here for your reference, but just to summarize the inclusion criteria, patients were included if they were less than or equal to 18 years of age on mechanical ventilation that used fentanyl or morphine for a period of greater than or equal to 5 days. Patients were excluded if there was a presence of any other opioid that wasn't fentanyl or morphine, presence of developmental delays, if there was presence of chronic methadone use, and if they were on methadone prior to the algorithm being implemented. So in order to assess compliance to the algorithm, patients were evaluated for the entirety of their methadone taper to determine whether each step of the algorithm was followed accordingly. A compliance algorithm that included 9 measures of compliance that was defined as yes, and non-compliance, which was denoted as no, was set. I included the 9 measures here on the slide for your reference to help depict how we measured and calculated compliance. It's important to note that in some patients, some measures were not applicable, and as each patient was different and evaluated individually on a case-by-case basis, and at each measure of compliance and at each decision point, yes or no was tallied to determine % compliance per patient. So in order to determine compliance, again, we tallied the total number of compliant decision points, which was the yes portion, and divided that over the total number of decisions, which included yes or no, to determine the % compliance per patient. We expected Stony Brook Children's Hospital to be 70% adherent to our protocol, and therefore made this the pre-specified threshold for compliance. We also tallied the total number of compliant decision points per the number of days on the methadone taper to help conceptualize the number of decision points per patient to the number of compliant decisions per patient day. Now to get into the results, just to further break down the enrollment of the study, there were 20 patients that met the initial inclusion criteria. After further review of the patient charts, there were 10 total patients that were excluded and 10 patients that met final inclusion criteria. I included the reasons for exclusion on the slide here for your reference. So 10 patients were studied ranging from 4 months to 14 years with a mean age of 3.2 years. I do want to preface that while I don't have p-values just yet, there was a notable and significant difference in the number of cases between duration of mechanical ventilation and the type of opioid used. The majority of the population was male, accounting for 60% of the population. 90% of the population received mechanical ventilation for less than 14 days, which I thought pertinent to include as this helps determine which side of the algorithm to follow. The majority of our patients were primarily on fentanyl as their continuous opioid infusion at the beginning of the methadone taper, and the average duration of the methadone taper was 10.9 days. Now to get into the primary endpoint results, the average percentage of compliance per patient was 59%, with only 1 patient achieving study-defined compliance at the 70% threshold. The lowest compliance rates were seen in compliance measure 4, which accounted for 42% compliance in patients not being weaned at the proper frequency. Number 6, which was had a compliance rate of 0%, which was failure to add the total amount of rescue doses in 24 hours to the total daily dose. And 8, which was 44% compliance rate. And this was due to not reducing the methadone dose at the proper 10 or 20% reduction per hour algorithm. So areas that we could improve on were dose reductions of continuous opioid infusions, which involved either weaning the fentanyl or morphine too often or not often enough, according to the algorithm specified frequency. Cessation of the taper or addition of the total amount of rescue doses to the total daily dose, in the presence of a rescue dose requirement when the patient needed it. So if this was applicable to the patient. And so a lot of times the rescue doses of morphine was not converted or added to the total daily dose of methadone when patients were withdrawing. And dose reductions of methadone were sometimes not weaned according to the 10 or 20%, with it often being reduced too much. So this is something that we can definitely keep in mind going forward. So now to get into our secondary endpoint of efficacy, in order for this algorithm to be efficacious, we would expect to see Watt scores less than or equal to 3, because remember, Watts greater than or equal to 3 signify withdrawal. Our goal was for 80% or more of all Watt scores to be less than or equal to 3. We measured this efficacy endpoint by collecting all Watt scores and then dividing the total number of those that were less than or equal to 3 over that total to determine whether presence of an institutional-based algorithm was beneficial in prevention of withdrawal. To get into the results, I included the initial dose assessment based on whether we converted in accordance with our conversion guide. 80% of patients received normal initial dosing based on the conversion guide, and based on our set definition of efficacy of 20%, the algorithm meets efficacy requirements in the majority of patients except one who exceeded the threshold as highlighted here. It's important to highlight that in the one patient who received lower than normal dosing in comparison to patient 1 who received normal dosing, the lower initial dose met efficacy while the normal dose did not. So one may argue that our set protocol for conversion could actually recommend lower doses. So that's something to keep in mind as well. The study has some limitations, including the fact that this is a retrospective review that involved a single center institution with a small sample size. The most important limitation is a lack of a validated compliance or efficacy threshold measure to support our study's definition of compliance and efficacy. So that is something to consider when evaluating these results. To conclude, while the overall rate of compliance fell below the study defined threshold of 70%, the overall compliance was not too far removed from this threshold, with the lowest percentage at 46% over the first 6 months of utilizing this algorithm. Despite this, the withdrawal prophylaxis algorithm still achieved efficacy in the majority of the population, according to our study defined measure. It's also pertinent to point out that there is limited literature to support our study defined thresholds of compliance and efficacy, and further literature is warranted to determine and validate that, as we don't know if 70 or 20% is sufficient. Perhaps a compliance of 60% is sufficient, but we don't really know due to the lack of literature to support this. Lastly, the study highlights need for all centers to constantly evaluate their own practices to determine educational needs and potential changes to any established algorithm to help further optimize patient care. And that concludes my research project. I will now hand off the next project to my co-resident, John Sher Khan.
All right. Hello, everybody. They saved the best for last. So my name is John Sher. I'm also one of the PGY1 pharmacy residents, for those who don't know me. Today, I'll be presenting my longitudinal research project on identifying the optimal concentration of heparinized percutaneous ventricular assist device per solution for cardiac intensive care unit patients at a university hospital. I have nothing to disclose, neither does my PI, Marie Varela. And I'd just like to acknowledge Marie for her guidance for this project, as well as her moral support throughout. The objectives for today are to examine the use of heparinized per solution and systemic heparin in patients with percutaneous ventricular assist devices, and to evaluate the optimal concentration of heparinized percutaneous ventricular assist device per solution. So just an introduction, cardiogenic shock is a life-threatening condition and is associated with multi-organ system failure and death. What is cardiogenic shock? So it's a state of inadequate tissue perfusion due to cardiac dysfunction. Most commonly is caused by acute myocardial infarction, and mortality rates for cardiogenic shock are relatively high. In literature, it's ranged from 50% to 80% of patients. The pathophysiology of cardiogenic shock involves like a downward spiral where ischemia causes myocardial dysfunction, which in turn causes worsening ischemia. Clinically, a patient would present as someone with hypotension that's refractory to volume resuscitation with features of end organ hypoperfusion. What are these markers for end organ hypoperfusion? Namely, it would be your urine output of less than 0.5 mLs per kilogram, altered mental status, as well as like paler skin. These patients will have increased preload and afterload, as well as decreased cardiac output. Percutaneous ventricular assist devices are these extracorporeal microaxial continuous flow pumps that provide hemodynamic support during high-risk percutaneous coronary intervention and cardiogenic shock. Typically, a synergistic approach is used with pharmacological intervention, namely inotropes and vasopressors, as well as mechanical circulatory support to optimize perfusion in patients with cardiogenic shock. So this is just an overview of the Impella device itself. So how does it work? So it's typically inserted via the femoral artery, retrograde through the aortic valve into the left ventricle. And there's two types of left-sided Impella devices. There's the Impella 2.5 and Impella CP device. And these can adequately maintain a cardiac output of 2.5 to 4 liters per minute. And that's just the arrow pointing towards that specific region. There's also a right-sided device that's inserted into the inferior vena cava to the pulmonary artery. And it'll also deliver a flow rate of approximately 4 liters per minute, kind of augmenting natural flow rates of the heart. What's important to note is Impella use is contraindicated in patients that have moderate to severe aortic valve disease, mechanical aortic valves, and severe peripheral arterial disease. And how this works is, since it's inserted and blood flow is going through, to ensure that this device doesn't clot, you have a purge cassette or purge solution that's involved as well, that they insert in patients. And to ensure that patients are therapeutically anticoagulated, patients will have this purge solution. In addition, they'll have a systemic heparin solution as well. And the Impella device itself is like a miniaturized percutaneous ventricular assist device. So you could picture it as like a pencil that they insert retrograde to the left ventricle typically. So this is just a kind of microscopic view of the Impella device. So in this image, the blood flow is from left to right, whereas the purge solution is flowing right to left. And this is used to provide countercurrent flow to the patient's blood, and it creates a barrier that prevents blood from entering the Impella motor. Typically, the purge solution is heparin, and it's used to maintain the patency of the purge pathway to prevent any blood from entering the motor itself. In patients that are contraindicated to receiving heparin, they'll typically use like a dextrose-based purge solution, and then use argatroban to ensure that they're therapeutically anticoagulated. What's important to note here is through a built-in pressure sensor, the device automatically sets and adjusts the purge flow anywhere between 2 and 30 mLs per hour to maintain an adequate purge pressure of 300 to 1100 millimeters of mercury, which is required to maintain the device from clotting. So a patient can be exposed to variable natures of anticoagulation in the midst of receiving this heparinized purge solution. This is the Impella protocol here. It's institution specific for Stony Brook University Hospital. It was established in January of 2019. And our patients receive 12 units per kilogram of systemic heparin. And then this value is subtracted from the Impella purge rate from the past hour. And typically the range that we're looking for is an APTT value of between 65 and 85. These patients will be initially monitored after 4 hours of initiation of the heparin purge solution, and then thereafter every 6 hours. And this is a nurse-driven protocol. So why go about doing this research? So the Impella manufacturer recently came up with a recommendation to use a more diluted purge solution. So typically in our patients, we used 25,000 units of heparin in 500 mLs for the purge solution. The manufacturer of the Impella device, Abiomed, recently came out with a recommendation suggesting that we use 12,500 mLs in 500 mLs of dextrose for the purge solution. And this was based on benchmark studies that they did, that they noted that patients were super therapeutic in their anticoagulation on the original heparin purge that they had recommended. What's important to note, as changes are associated with the use of time and resources, and therefore you have to evaluate the need of a diluted heparin purge in an evidence-based fashion to ensure that it is something that's required in your institution. So the primary objectives of my research project are to determine if there is a need to lower the concentration of the heparinized percutaneous ventricular cyst device per solution for cardiac intensive care unit patients at a university hospital. The co-primary endpoints are to determine if the current PERT solution alone resulted in therapeutic or super therapeutic APTT values, and as well as to determine the percentage of patients achieving or exceeding the protocol defined therapeutic APTT range. So just getting into methods. So this was a retrospective chart review. It was a quality assurance quality initiative observational study from January of 2019 to September 7th of 2021. We use the electronic medical record and medication administration record, and the inclusion criteria were adult patients, Impella implantation with the use of heparinized PERT solution, patients specifically in the cardiac intensive care unit, and those patients that received the Impella heparinized PERT for a minimum of 6 hours. And then we excluded patients from the CTICU because they use a separate protocol. Typically, it's a provider-driven protocol in the CTICU, and they tend to use a dextrose-based PERT solution so that they can kind of adjust the systemic heparin the way that they prefer. We excluded patients that didn't receive any APTT values, patients that had heparinized PERT for less than 6 hours, patients on ECMO support, any patients that had contraindications to heparin use, patients that are transferred from an outside facility, as well as patients that received a purge without heparin or alternative anticoagulant. And so our study population was initially 130 patients that received the Impella device, and based on various exclusion factors, including less than 6 hours on the Impella support, CTICU setting, factor V Leiden syndrome, as well as heparin-induced thrombocytopenia history, and then patients that are transferred outside from outside facilities. So we ended up with 38 patients that met our inclusion criteria. These are the baseline demographics for your perusal. What I did want to point out here is that the median age was around 67 years old. It was typically a male gender patient, about 80% of our patients. And the Impella model that we used was typically for the left-sided kind of cardiogenic shock picture. So the 2.5 as well as the CP were the majority of patients, with only 2 patients receiving the right-sided Impella support. And the median duration of Impella support was 42.75 hours. So the results from our study is that none of the patients reached therapeutic APTT with just the heparin PERT solution alone. There were 2 patients that reached super therapeutic APTT with the heparin PERT solution alone. And then the majority of patients, about 95% of our patients, reached super therapeutic APTT, therapeutic APTT with the heparinized purge as well as systemic heparin. And we defined therapeutic APTT as 2 consecutive tests within the APTT goal of 65 to 85 seconds. Another analysis was the amount of our patient population that had therapeutic APTT values. So 95% of our patients had therapeutic APTT values, and 5% of our patients did not, or they were super therapeutic. So like I mentioned, making improvements that require resources have to be carefully considered in like an evidence-based fashion. What our recommendations are based off our conclusions from the study is that a diluted purge solution is beneficial. It'll help reduce the risks of having to change a purge mid-therapy. It'll allow us to standardize our heparin purge solution availability in both the CICU as well as CTICU, and it'll reduce the number of available concentrations of heparin in accordance with ISMP recommendations. So heparin is on the high alert medication list for ISMP, and it's strongly suggested or mandated that institutions have the lowest amount of standardized available heparin purge solutions, as well as like systemic heparin available. So that will help us reduce any like med safety errors that might occur. So the conclusion from my study is that the practice of anticoagulation for Impella devices is variable and kind of difficult to assess. Our study provides descriptive outcome data supporting the use of a lower concentration heparin purge solution of 25 units per ml. And further studies assessing clinical outcomes when utilizing this less anticoagulation are needed. The limitations associated with the study is that it's retrospective in nature. It's a quality assurance, quality improvement project, and it's an observational study with no control group. We had a limited patient population of only 36 patients. We didn't observe any clinical outcomes, and certain variables such as like the pump model that we used, demographics, whether a patient was on dialysis or not, were not controlled. And since it's only a retrospective and descriptive study, it's not hypothesis generating. And these are my references for your perusal. One thing I did want to note is that the outcomes from this study, we're currently in discussions with the administration as well as attending physicians from the CICU. Based off the results from the study, we will be looking to transition our patients from the 25,000 units per 500 ml heparinase based purge solution to the more diluted 12,500 ml heparinase purge solution. And that'll be the conclusion of my presentation. If you haven't done already, please write your names within the chat so we can ensure that you receive credit for attending this CE presentation. And other than that, we all appreciate your time. At this time, I'll open the floor for any questions at all that you might have for any of the 4 residents. Again, like just ensure that everybody gets credit for the CE presentation. If you haven't done so already, please put your name within the chat so we can just ensure that you get credit for attending. Thank you. All right, if there's no questions, we will conclude our session. Thank you all again for attending. We hope that you found our longitudinal research projects relevant to your clinical practice. Thank you.